All right, good evening, everybody. Thank you for all tuning in here for our first pediatric panel in celebration of EMSC Day, which was actually May 22nd, but we like to keep the party going. So we're gonna be here today to, we have an awesome pediatric panel of a bunch of different background and expertise to answer pediatric questions. And so we're really excited to get going with you guys and start that process. But before we do, I wanted to just take a minute to kind of explain briefly kind of what EMSC is and kind of what the mission and the purpose of EMSC is, because we are here celebrating that. So Emergency Medical Services for Children was started as a federal program to basically ensure that all pediatric patients, no matter where they're presenting with their injury or illness, are receiving the highest level of care possible. And so we do recognize that pediatric care does have, other emotional, also equipment needs and differences with physiology that make it, maybe more challenging. And so they've designed pediatric readiness as well as disaster preparedness aspects to help so that everybody can be as prepared as possible when caring for pediatric patients. And so we're here kind of celebrating that. We have an advisory committee with our EMSC program here in Minnesota, and we have a lot of our panelists here are committee members. And so before we get going, we're going to have us go around and kind of explain who we are and our background so you can kind of get to know who we are. And then we're going to take a moment to actually get to know who our audience is so that we can help serve you the best way possible when answering these questions tonight. I know we gave you an opportunity to submit questions, but if you have any questions that come up during this panel, we would love you to put them in the chat, and we'll try to monitor that and answer them as we go or at the end if we can. And we want to thank you all for the care that you do provide the children and youth in our state. We're very grateful for the care you're providing them and that you took time out of your day-to-day to join us. And we do recognize some of you may be tuning in from work, or you have colleagues who are working and can't tune in. And so this is being recorded so that we'll be putting it on our YouTube channel so that spread the word. So if you want to listen later again, if you have to step out for a call, or others want to be able to listen in, make sure that they check that out. And just for your own knowledge, we do have a great website and a YouTube channel that does have additional resources and opportunities to check out. So afterwards, please take a look at that as well. So without further ado, we'll take a second here to introduce who's on our panel, because I'm very excited to be a part of them all today. I'll start. So I'm DePomps, or also Anna DePompolo, and my background is a pediatric emergency medicine physician. I've been the medical director of EMSC for about the last 2.5 years, I think, and have really enjoyed being a part of the mission of EMSC, and look forward to where we're going in the future and helping support all of you in your pediatric care for our children in the state. So I'm going to pop it off to Melody here to introduce herself. So
my name is Melody Schreiner. I am the trauma and critical care clinical support liaison for Hennepin Healthcare. My background is in nursing, specifically pediatrics and emergency medicine. And then I've also joined into EMSC as one of the advisory board members, and I support Hennepin EMS as well.
My name is Christopher Kovaleski. I am a pediatric emergency medicine doc out of Masonic Children's. Recent, committee member to EMSC, so excited to take part and meet you all.
And I'm Kirk Hughes. I'm the education director and a poison specialist at the Minnesota Regional Poison Center. Sorry, we just had a recent name change. Been there for 26 years, and then I've been doing EMS for 29 years.
Hi, good evening, everyone. My name is Tracy Larsen. I am a pediatric trauma program manager at Regions Hospital in downtown St. Paul. I've been there for about 20 years with a background in emergency medicine and trauma, and I joined EMSC back in 2013.
Nice. I'm behind the scenes. Hello, everyone. My name is Chelsea Paulzine, and I am the program manager for EMSC. And I'll be in the background here doing all the tech stuff. So if you have any questions, let me know.
Yeah, and we do have kind of a hybrid panel tonight. So we do have two on the web, I guess I would call it. And so I guess I'll let Meghan, if you want to go ahead and introduce yourself, and then Maria.
Yeah, I'm Meghan Cain. I'm one of our pediatric emergency medicine physicians at Mayo Clinic in Rochester. And I serve on some roles there with trauma and other leadership things.
Excellent.
Hi, everyone. My name is Maria Flor. I'm the trauma system coordinator for Minnesota, and I've been on the EMSC committee since starting that role last fall. I'm just happy to be here and glad you could join us.
Awesome. Well, thank you again to all of our panelists and to Chelsea getting all this information out to you guys. So I think we have a couple poll questions now, so we get to know you guys a little bit better. So if you want to take a second and you should be able to see the questions on your screen and fill that out, that would be great. And again, we're really glad you're all here with us. All right, great. Thank you again all for your care that you're providing out there. So that's the second question here. All right. All right, kind of a smattering across the board here. All right. All right, another one. Oh, I think. Oh, awesome.
Nice.
Great, we're excited you all are here. I think, do we have like
Got two
two more questions? So keep them coming. We're really appreciative of the answers here. All right. And I think we have one more question kind of taking off of that one. All right. Well, great. We're glad you're here today. So we're hoping that you'll gain some information that you can take back, and maybe we can make everybody feel great about pediatrics. We want to. We're excited about them. So. All right. So I think I'm going to hand it over to our moderator here, Tracy. So she's going to start posing some questions to us. And again, at any point, please feel free to pop something in the chat. We'll keep an eye on that.
Yeah, absolutely. It's really nice to see all the EMS agencies out there. It looks like we have a lot of rural providers that rarely to moderately take care of kids. And so the very first question we have is going to fit right into this group of people. So Dr. DePomps.
Yeah.
So because you gave a nice introduction of EMSC. So one question was, I work in a small remote area. What resources exist for pediatric readiness?
Yeah, it's a great question. So for sure, if you check out our website, EMSC Minnesota, we have some actual links to some resources as well as the pediatric readiness, which I would definitely invite if you have never taken a look at that document. It's a pretty easy, basically several pages, but of questions that are posed to ask these questions about whether you have instruments or what protocols are in place and kind of who is even at your institutions or agencies to kind of provide that pediatric support. And so, and I think we have a slide possibly with that website information too. So we'll get that to that. But I mean, I definitely suggest that. I mean, even the our website definitely has those resources. I don't know, Maria too, I think as from a state standpoint, do you have any recommendations too of where they might go for some of that information as well outside of our webpage and the pediatric readiness information?
That's the first place I would recommend looking. It's a great resource, good starting point. Yep.
Yeah, and it's pretty easy to use, and you don't have to have, you can be anybody to really, start answering those questions or, you can pull it up. So I think it's a good resource.
That's great, and again, if any of the panelists have anything, and we're going to continue to monitor the chat, but also, so the National Pediatric Readiness Project, it's a mouthful. They have a pre-hospital and the emergency department toolkit and checklist. You guys have most of this equipment. It's having your equipment on the Broslow and different kind of policies and procedures. And I think for especially rural EMS, it's just knowing where to take your kids if they're sick or injured is a very nice way to start that. But they do have a lot of their National Pediatric Readiness projects are focused for EMS providers as well as ED.
Thanks, Tracy.
Yes. So how can people stay informed about pediatric readiness? And can anyone talk about what they feel? They've heard the word PEC, pediatric champion. Sometimes that's a EMS provider, a nurse, a physician. Anyone have information on how to become one or what they do?
Well, I can definitely take this one because if you check out our YouTube page, you'll see a video of myself demonstrating how to become and what it is. I think we're having some feedback, so I'm sorry if that's coming through. But anyway, so check out the YouTube page. There's a video that kind of explains what a pediatric champion is. Also, if you go on our website, there is also a kind of a button or a link also to becoming a pediatric champion. But basically, as Tracy, you alluded to, you can have any background, really, just basically a passion for providing care to pediatric patients and wanting to be that champion at your agency or your institution to really drive that care and ask those questions and be involved. And when you become a champion, you also get some additional resource availability. So we have some presentations and education that will become available if you become a pediatric champion. And so there is definitely some benefit to that. And if you aren't already a pediatric champion, I would strongly encourage yourself, or if you want to delegate that to somebody within your agency, we really want to strive to have a champion at every site in Minnesota. And you will be able to be informed, like we talked about, with pediatric readiness, as well as just, upcoming concerns or issues regarding pediatric care. So I had to steal that one, Tracy, because I'm a little vested in that one. And if you see the video, it's "We want you," and I'll put it out there again. We want you to be a pediatric champion.
That's awesome.
Sorry.
No, I think that's great. And here's one that makes a lot of people uncomfortable, not only if you're a kid, but Melody, you work at a burn center. So what should an EMS provider do if they are called to a scene or a hospital to transport a kid that fell into a bonfire, campfire, it's campfire season, that has significant burns to their body?
It is campfire season, and actually doesn't even need to be significant burns to get those kiddos to a burn center. Any burn greater than 10% of their total body surface area should come into a burn center. Here in the state of Minnesota, we have the burn center at Hennepin Healthcare and the burn center at Regents Hospital that are both capable of caring for adults and pediatric patients and entire families. So if you are an EMS provider and you're bringing in multiple family members, try and get them all to go to the same place just to keep those families together with that. So know those and be quick to transfer those patients, get them to the ER and get them stabilized. But if you're also then transporting to the burn centers, remember pain management for the kiddos. Small, frequent doses of narcotics is what's appropriate. Intranasal, if you do not have IV access, if not IV, try and avoid IM if at all possible with that. The metabolism on these little ones is high, so you will need to give more frequent doses with that. Your fluid resuscitation is always brought up if you are starting to resuscitate, if their kiddos are less than the age of 5, LR or normal saline at 125 an hour. If they're between 5 and 14 or 6 and 14, you can start those fluids at 250 cc's per hour and just let the receiving facilities know that you did start those fluids. If you have time to get those tetanus shots updated, that is very important with burn patients. And as far as dressings go, clean dressings are great. They do not necessarily have to be sterile. Once the kiddos are to the burn center, they will be sedated and debrided. So just clean things are great. Please, no more wet dressings. We used to put, entire wet sheets on our patients, and they ended up getting hypothermic. And as we know, with trauma, we do not want to get our patients cold.
That's especially true when it's really hot and humid here, right? Yes, thank you for that.
And Melody, would you say a rough estimate for gauging percentage of body? Obviously, there are those charts, but don't we usually say about the size of their palm is about 1% too? So
their palm with their fingers is about 1% of their body. Their palm, not you, the provider. I've seen providers take like a piece of paper and trace the kiddo's hand and then kind of guess how many handprints they are and such. Don't worry about getting that number correct. Burns take about 24 hours to really declare themselves as to what is, second degree versus third degree and such. So just get it going, and we'll use the experts at the burn centers to get that more accurate percentage. And we get it wrong pre-hospital, and that's okay. We just want that recognition that these are serious injuries, and these kiddos need the best care possible.
Wow, thank you for that. That's a lot of great information, especially with such an isolated injury. For the fantastic pediatric EMs that we have on our panel, what can EMS do, whether they come on scene or transporting pre-hospital when a child has a fractured limb and is in significant pain?
Yeah, I can take this one. So I think the biggest thing is just reassuring the patient or the child. So I think if parents are there, encouraging them to be close and comfort them. Pain medications are always a plus. As mentioned before, intranasal is a great point of access for medications. Intranasal fentanyl in particular is one that I use a lot of with broken bones. That in mind, using appropriate dosing weights and appropriate medication doses are also important.
What about, do you recommend immobilizing?
Yeah, there are some prefab splints. I don't know if some crews carry on their rigs, but trying to immobilize in a position of comfort just to limit movement and potential worsening of that fracture.
Great, thank you. Dr. Cain, did you have anything to add? You had unmuted for a second.
I was going to add immobilization as well. So you got it right there.
All right. Well, since I have you unmuted, how would you recognize a child that has sustained some traumatic injuries as non-accidental trauma in your emergency department?
Ooh, that's a good question. And this one's always tricky. Things we think about are, is there a pattern to the injury, whether it looks like a pattern? Does it fit with the story that we're told? If a kid can't walk and the parents say, well, they were walking, you're like, well, they're not old, they're 4 months, they're not walking. So how did this injury really happen? There's also some mnemonics about the locations of injuries. So if we see ear injuries, that's highly concerning for non-accidental trauma. If we see injuries really in the face, like in the mouth, intraoral injuries, non-accidental trauma is a concern. So generally it's kind of what do the injuries look like? Does the pattern really fit with the story that we're being told? And And whenever there's a question or concern, I think it's always good to vocalize it and to say it to everyone that's around you. Are you concerned about this? Because as I tell the families, you know, it's uncomfortable to have that conversation. I'm not the police. I'm just there to make sure that their kid is safe. So it can certainly be tricky to identify kids, but just kind of keeping an open mind and making sure what you're hearing really fits with the patient and their developmental level.
Okay, great. Thank you for that. And to kind of, there was something that came up in the chat when we talk about immobilization in pediatric trauma. And somebody had asked, what's the best way to gauge the need for a C-collar in pediatric patients? Those are, I'm going to leave that for, I have my bias. But, you know, for the pediatric emergency medicine specialist here.
Yeah, I mean, I guess I think it is a tough one, right? If they can't communicate to you. And so I think if there's any concern there was a head injury and they're non-responsive, I think it's always safest to put them in C-collar, you know, and use C-spine precautions. I think if a kid is literally screaming and wrenching their neck all around, it's probably reassuring that they don't have a spinal injury. I think most children who are really injured are going to probably splint themselves and, you know, not move. But I think if you take the mechanism, if you know the mechanism at hand into account, I think that will be helpful. And I think if you're at all worried, nobody's ever going to fault you for taking the precaution and putting them in a splint and using those C-spine precautions. We'd much rather have you err on precaution and care and us, you know, getting them there and maybe clearing them pretty quickly then. But I think it can be very confusing. And I don't know if Chris or Megan, you have other thoughts with your practice, but that would be what I guess I would say.
No, and I would echo a lot of that. I think if you're at all worried, either from the mechanism or if they're splinting themselves and not moving their necks, then nobody's going to fault you for putting them in a C-collar. It's uncomfortable, but until they can get to the ED, get cleared, I think it's better safe than sorry.
Yeah, I 100% agree with that.
All right, thank you for that question in the chat. We do have an expert here from poison control, Kurt. So, you know, edibles are out there and good heavens, what happens when EMS is called to a school? Or what happens if they're called to a hospital or a scene because a child is now altered, presumably from some type of an edible?
Yeah, this is an all too common call. This is a multiple daily call for us at the Minnesota Regional Poison Center. As all of you know, marijuana or cannabis is still Schedule I federally, so there's been no prospective double-blinded studies. Hopefully that's going to change here. There's some whisperings that this administration might make it a Schedule III, which would help things, but now the cat's been out of the bag, and I don't anticipate a lot of those studies moving forward because it costs a lot of money. And now that the cat's out of the bag, they're not going to pay for a lot of those, in my opinion. But for adults, we don't get too concerned. I have not had any serious morbidity, mortality from a medical perspective in adults using the edibles. The children are a different story. We do have multiple incidences where we just had one the other day that had seizures. And so we're seeing respiratory depression and arrest. And our friends across the pond over in France have had some papers published because they've been seeing edible marijuana longer than we have in the United States, showing that there's respiratory depression and arrest. I know that we've had, at least to my knowledge, 5 kids that have needed to be intubated because of respiratory insufficiency secondary to edible cannabis products. We're seeing seizure or seizure-like activity. A lot of these are reported by family and they're not totally aware of what a true seizure looks like. But we do have also seen some of these children in the ER and in the clinical setting that have had true seizures. We had another child that was flown from Wisconsin to one of our children's hospitals that was supposedly had an asystole incident 13 hours after. And all these cases, what was implicated was by blood and or urine that only THC was responsible for this. So since we've never done any good clinical trials on this, we're basically using our kids kind of as guinea pigs, so to speak. So, and usually in our experience, and all I can talk is anecdotally, and so I take somewhere in the average about 20 to 30,000 or 3,000 to 5,000 calls a year. and I've been doing this for a while, and I only do it half-time. The other half I do the education stuff. But I can tell you that most of the kids that we that experience a serious morbidity would be the children that are about 4 years old and under. And that's just looking at the data kind of anecdotally that my experience has been. So I would say any child that's especially under 6 years old that is having any symptomology needs to be seen and evaluated at an emergency room. As far as the kinetics go, we're really not sure, because when you ingest cannabis products, it turns into 11-hydroxyl THC, which is much more psychoactive and much longer acting. So it's not like when you smoke it, it goes away in 20 minutes. We've seen kids be symptomatic for up to 24 plus hours.
And I'll put a plug. Kirk has a video on our YouTube channel that does talk a little bit about poison safety. So again, check out our YouTube channel. But also, Kirk, you've also been seeing more fentanyl too, right, in our pediatric patients. I know we've kind of chatted about that a little bit too when we're talking about ingestions. And
yes, we have indeed. So just at the Poison Center, we've had 66 incidences since mid-2022, and that was through the end of 2023, where pediatric patients under the age of 6 have gotten into fentanyl. And that's mostly a function of there's more fentanyl out there. And since there's more fentanyl, there's more availability to children in homes where people have opiate use disorder, where they're not, maybe supervised as well and that sort of thing. But the good news is that naloxone is available to everybody in the state, and anybody can give it, and it can only help them and not hurt them. So.
Do you know off the top of your head, one EMS question that came in is the dosing for Narcan?
So it depends on whether you're ALS or BLS. I know that ALS has the ability to go ahead and, obviously get a line, get IV access or IO access. And most of the time they start at 0.4 or 0.5, depending on the formulation that it's in, and they'll go up slowly. Some of you out there in EMS obviously know that us in BLS only have the 4 milligram intranasal, which is actually the equivalent to 2.1 milligrams IV. Can sometimes be too much in people that have opiate use disorder, and you can put them into withdrawal and they say interesting things about your mom. But for pediatric patients, unless they have opiate use disorder, they're born that way, you don't have to worry about any of that. And so you can go ahead and just go to guns on it. And so I would say in this state, in Minnesota, all law enforcement by law has to have 2 of the 4 milligram intranasals. And then most of BLS in the state do have that. So I would say go ahead and empty them all if the child's unresponsive. And if it's not opiate related, no harm, no foul. So I would start with the 4 milligram and just go up from there rapidly.
Well, that's a fantastic answer, especially for a lot of the rural EMS agencies that we have on here that may or may not encounter kids. And then on top of that, kids that have had some type of OD. We know that pediatric overdoses is on the rise, and so unfortunately is mental health for children. So I'm going to turn to our Peds EM physicians to tell the panel and to tell all of our participants what you're seeing and what would EMS expect when they bring a child that's having a mental health crisis to your facility.
Yeah, I can take this one. So I think, as mentioned, we're seeing a lot of mental health crises, I think probably across the state, probably across the country. It is unfortunately a lot of what I do now. So just to give you a little bit of peek back behind what we do in the emergency department, just to speak from a place of empathy, these are kids in crisis, probably having the worst days of their lives. Typically they're brought to the ED because we're a place of safety. We can keep the kids physically safe. We can prevent them from doing things with consequences. So usually when EMS brings them by, either willingly or potentially chemically restrained or physically restrained if they're the harm to themselves or others, they get seen by an ED doctor to medically clear them. If there is potential ingestion on board or any other concern, we can try to rule out anything else that may be contributing to that altered mental status. And then once that aspect of the visit is over, we then proceed on to the mental health evaluation. That's usually, at least in our shop, a psychiatric social worker who goes through kind of the history about what might have triggered this event, how can we keep them safe, what kind of short-term and long-term management options there might be for this child. That usually looks like something like discharge with outpatient follow-up with a therapist. Sometimes it's partial hospitalization, and then for the very acutely ill, kids who are at high risk for hurting themselves or others, that may look like inpatient psychiatric admission. I will say that unfortunately there's quite an imbalance between the number of inpatient mental health beds than there are pediatric mental health patients. So oftentimes these patients wait in our emergency departments hours, days, and unfortunately sometimes weeks, depending on the acuity and on their specific scenario. I think important for y'all to know is we don't typically start medications in the emergency department. This is something we leave to our specialist, the pediatric psychiatrist. A lot of what we do is stabilization and keeping them safe until we figure out the next best step. I don't know if you guys have anything else to add.
No, I think that's a pretty summative.
One, again, just a shout out to a lot of times we have issues where parents are hoping for an acute psychiatric visit, hoping to start medications, and unfortunately that's just not what we're able to do, and we're not capable of providing that immediate evaluation or care. So our focus is more on stabilization and keeping them safe.
Yeah, and often a big team player with social work too is helping us with that, so.
Which unfortunately means that they sometimes board in your emergency departments?
Yeah.
For a couple of days.
Yeah. Which can be really tough on families too, and the kids, because those rooms are often no windows, they have a lot of their personal items taken from them, put in scrubs. We just standardize all mental health because you don't know which kid is the one that could be a harm to others or themselves. And so I think having them be aware that it's going to feel, I'm sure it doesn't feel good to have all those things that you identify with taken from you, but it's just kind of standardized for safety measures. And so, that's a big deal too. They're not going to probably be able to talk to their friends and
Right.
outside of social work blessing it and providing,
Right.
So.
But it's good information for you folks on the out in the audience there, just to maybe have that conversation as you're transporting that this might be the expectation when they get there, because that is probably holds true for all the local hospitals here. So the weather's getting nicer, pools are opening, lakes are opening, cabins are opening. What do we do as EMS providers when we encounter a near drowning, either freshwater or cold water? Does anybody want to tackle that one? Did you say something, Meghan?
I guess I'll start. I still get palpitations when I go to lakes with big swimming areas. So I guess, the biggest thing is obviously if they're in arrest, then you're going to be doing your PALS algorithm and following that. If they're cold, and they're probably cold, even if the water's warm-ish, it's not really as warm as your body temperature, and they've probably been down for a while. Usually drowning, unless you're in a pool, they're not really necessarily noticed right away. They're probably going to be cool. So trying to get them warm, getting them to the closest facility where they can get, if we need to get advanced airway, if that's not able to be get during transport, depending on who's transporting, but really just following your PALS algorithm. Certainly there's lots of fear out there about dry drowning and other things in the not acutely arrested patient, which is kind of a whole separate thing. But, if the kid is alert and they have an intact airway, then, bringing them in for evaluation, if there's any sort of submersion injury, is very reasonable. But those patients, I think, are nice when they're stable and not the true arrest patients. I don't know if there's any more specific answers others have.
No, I think going back to the sea collar thing, like if it's a teenager or somebody who is found down, to consider, did they dive? Did they have an actual spinal injury or head injury with that drowning that might have happened? So just kind of considering that again when you're assuming things. But yeah, I think And then, I mean, the kid is coming in, I feel like we usually will observe them, you know, in the hospital for, you know, I think there's varying, but like maybe even up to 12 hours just to monitor oxygen and work of breathing. Cause, you know, depending on, you know, if there was any further aspiration of water or irritation to the lungs that could develop, we kind of continue to monitor them if they're alert and breathing and maintaining the airway. So.
Yeah, I think that's great, you know, and especially for the, for any of the EMS providers out there, not to forget your good quality CPR, opening that airway, because, you know, we just had a 9-year-old and she is a huge success story, CPR for 3 minutes, and she was recently discharged. She's got no deficits. We did the same thing as you said. We observed her, but it was that good, high quality CPR and getting them to the right facility. So just if you know you're going to a pediatric drowning, just bring your resources because we all use our resources.
Mhm.
So, all right. Great question. I'm still monitoring the chat. But let's say, you know, we've talked about burns, we talked about ODs. What about kids that have polytrauma? And, you know, for the life of me, I can't get IV access. Where is the best place to put an IO?
I mean, yeah, I mean, so I mean, I think obviously, you know, you could do tibial or distal femur would be kind of the proximal tibia or distal femur in kids. I mean, I guess depending on the size, you could even use the humerus if they're a larger, I guess, child, or I mean, a teenager would be options as well. So, I mean, even the sternum has been used, but I would think in a pediatric, you're going to be using more your tibia, femur, or humerus. I don't know if Megan or Chris, you've got other thoughts on that one, but.
Yeah, I mean, I guess from anecdotal experience, I typically go for the proximal tibia. If you just feel like right beneath your knee along the, what is that, anteromedial aspect, that flat part of your shin right there, that's usually pretty easy to feel. There's usually not a lot of fat there. And the best part is if you miss, you can go for distal femur. So one of the contraindications for IO placement is a failed attempt somewhere kind of proximal, because otherwise if you get it distal, it'll just shoot out the previous hole. So don't do that. The other big mistakes that I see or anecdotally have had is people push too hard. So you can definitely go through and through. So just going until you feel that pop of getting through the marrow and then letting go. Because people just want to hub it because it's a kind of a low incidence, high acuity event. And you get very anxious and energized and excited. So just only going until you feel that pop.
Remember, if you're using that distal femur, especially those kiddos that are not walking yet, that have the giant pudgy thighs, that you might need to upsize your needle. Don't use the pediatric, use either the adult or actually the bariatric needles for those.
That's a good point.
Yeah, I would echo that point. That's an important point. There's just needle size. So it's more based on the patient's fat stores than perhaps their age.
They're all the same gauge,
Yeah, just
different
aim
lengths.
big.
Yeah, that was maybe my point too. I've seen a lot of failed babies because the pink one is too short. Like you said, there's all that adipose, and so going longer and it's easy enough to go in this far, but I would agree.
Great, thank you. Those are some great suggestions and some great answers. But you know, Kirk brought out something like sometimes these kids that OD, whether it's on prescription meds or THC, and they're seizing. How do EMS providers care for a seizing child, and what would be their first line of defense, whether they're getting them out of a school or out of a home, or they start seizing in the back of their rig?
Yeah, so I think that's a two-part answer. Number one, from the BLS perspective, obviously there's not much we can do at the BLS level. Unless you're advanced, then you can only get an IV started, which is hugely advantageous if you're doing ALS intercept. From a BLS perspective, your biggest thing is getting a history and finding out potentially what could be causing that seizure. You know, whether it's disease, whether it's poisoning, trauma, et cetera, because that history is going to be hugely helpful, and you guys are the boots in the ground responding and can ask those questions. Number two, from a BLS perspective, would be just to help prevent the child from maybe biting their tongue and hurting themselves by thrashing about and hitting their head, and maybe sustaining some further head trauma or some addition or head trauma, period. From an ALS perspective, it's really easy. Toxin-induced seizures, it's benzos, benzos, benzos. And don't be scared to give benzos. I know I talked to some people that are like, well, this kid's really agitated and he's seizing. And I said, well, how many milligrams of Ativan have you given him? Well, a half. And it's like, you can go way more. So we love benzos. So that's kind of the short answer.
Just to kind of echo that point, one myth I often hear is that people are worried from the respiratory depression standpoint of giving benzos. I would say, and back me up, if I'm more worried about a kid who's been seizing for 30 minutes as opposed to a kid who gets an appropriately dosed benzo. So absolutely give the benzo, stop the seizure, because that's the kid I'm worried about intubating.
Yeah, and nasal Versed a great option if you're having trouble with IV access. We use a lot of that.
That's great. So how about, let's turn a little bit toward maybe some of our sicker kids that you're transporting, whether you're ALS or BLS, and you know, EMS gets called to a house or called to a critical access hospital because they have a child that's having a asthma attack that is wheezing significantly. What are some important things to remember in transport? You know, Kirk, from an ALS, BLS standpoint, from our EM physicians, how do you want to see these patients transported and presented?
Can I just add a little plug here first?
Plug away.
So I'm retired from Brooklyn Park Fire. We are 8th largest city in Minnesota. I did 17 years there, and we had all the variances by that was allowed in the state of Minnesota. We're one of the few at that time, and still in the minority, of BLS entities that can give albuterol in the field. I would, if there's any EMS medical directors here, any people who do training for the EMS who can advocate with their EMS medical director, I would highly recommend getting them trained in albuterol because it is a variance that can be had. There's extra training involved, obviously, but I think it's hugely important for BLS, especially in the rural settings, to go ahead and have that. Hugely advantageous. With that, I'll leave that to the experts.
I did not know that. Awesome.
Yeah, I mean, I think if you are picking up from somewhere, just maybe questioning, do they get steroids or you know, we love steroids out of the emergency room for any airway practically. And so, you know, it's not a bad question to ask, or if, I mean, I don't know if you have a protocol that allows for that or even carry that, but, and then, I mean, we even would consider doing continuous albuterol. So it's, you can continue to give albuterol if you have a kid in distress. You don't have to necessarily stop administering it if they are really struggling. You can always consider, you know, like flow. So, you know, we've used high flow or other, you know, ways to deliver more of that PEEP or pressure too. But if they're really working, and use that often with continuous too. But, you know, I think those would be some of my thoughts. I'm trying to remember all the questions, the layers of questioning there, but.
Well, and as you're transporting, remember to keep that kiddo in a position of comfort.
Yeah.
We don't want to make them lay down. You don't want to try and stress them out and make them any more anxious than they already are because they can't breathe.
Yeah.
So do the best you can to keep them calm and their parents calm.
Yeah. Yeah. Invite their parents to support in some way, whatever that is. So.
And then I think another point is kind of with the question on that's being shared is not all wheezing is asthma, right? So is it anaphylaxis? Is it foreign body? Is there something else? So like you said, keeping an open mind, and is there something else? Oh, it's anaphylaxis. Let's give epi. That'll help. That'll help asthma too, but.
Yeah, so I think that's a really valid point. Or even sometimes I feel like stridor can sound like wheezing, but it's actually croup, and you would do nebulized epinephrine versus albuterol. So I think that is, you know, kind of trying to tease out, is it wheezing only in one side versus both sides, or kind of what you're hearing? So I think that's a really good point.
And I think one more plug from an EMS perspective is get good at doing lung sounds. And I know a lot of times in the cities, we, as a BLS entity, with ALS on the scene, usually as quickly, not so much anymore, but pretty quickly, is if you have time, especially in the rural environments, get good at getting lung sounds. The only way you're gonna do it is by trying it. So what I do when I have my family get-togethers is that everybody, young and old, all get vital signs and they all get their lungs listened to, so.
I think too, like history is helpful too, right? Like asking
Absolutely.
like, what was happening before this? Was it, were they eating popcorn or a peanut and they're not at an age that should be doing that, which might make you think foreign body, or, were they outside and, playing in, the weeds and now have hives and are having trouble breathing. So I think sometimes just getting a little bit more history to put in context what you're seeing with and hearing can be helpful too.
I would say just another plug for that. Most pediatric disease that I think you're going to see is respiratory. So getting very comfortable with pediatric lung sounds, wheezing, respiratory distress, signs of increased work of breathing is crucial to the care of the child.
Pediatric assessment triangle.
Mm-hmm.
I'll say that 10 times because it's a wonderful tool.
These are the legit calls of using 911. If this kiddo's having trouble breathing, we've got to act quick. Otherwise, we're going to end up needing to use our pals. Nobody ever wants to use their pals.
Correct.
No, but I like the plug for EMS because wouldn't it be nice if EMS brought you this wheezing child that said, I talked to the parents and they're allergic to peanuts. They were at a birthday party today. We don't know what else it is. It came on suddenly, which is more of an anaphylaxis than an asthma, or the patient's been intubated before with an asthmatic type of, signs and symptoms. So that's definitely a great way for EMS, especially BLS, if you're in a rural area and you don't have a lot of the resources to get that past medical history and your sample history to give that to the receiving facility. So I'm checking the chat, but I'm going to quickly pick on Maria Flor here. So
Thanks, Tracy.
yay! So I'm looking here. One of the questions is, I'm still afraid to take care of kids. What resources do I have that are out there? What are some things that the Department of Health can offer you as a prior TPM at smaller critical access hospitals? What education, whether it was 4-year nursing or pre-hospital, do you feel was most effective?
Yeah, I think there's a lot of things. Admitting that it terrifies you is the first step because you're in good company. That's how most people feel. And just remember your basics. When in doubt, go back to ABC, do those basic things, bring a friend. Don't think you have to figure it out all by yourself, right? But partner with your neighbors. So if you're an EMS crew, ask your local hospital or where you take most of your patients if you can do drills with them or train with them because they have ongoing training. Some of the best education and training opportunities that I've been a part of have been collaborative between EMS and the local hospital. Because in real life, that's who you work with anyway. There's a handoff and so you're collaborating all the time. But they do various trainings. Some, like Rural Trauma Team Development course, is specifically for all the different disciplines. It's not just for nursing. It's for the providers, the nurses, the lab folks, EMS, your X-ray tech. It's meant for the entire team that cares for an injured patient to come together and learn how does this work together. But yeah, disaster drills, every hospital has to do emergency management. So they're required to do disaster drills, and at least, I think it's at least one has to include some community partner. So raise your hand and say, pick me, because it's a great opportunity. Invite some of your colleagues to come to your meetings. I used to go to EMS meetings and offer education or just, whatever the question's about. So if it was about how do we take care of this pediatric thing? Then that's what we would cover. Or if you wanted to see tools or equipment. Yeah, I think collaboration is key. And if you don't know your contacts or who to ask at the hospital, you can reach out to us. Otherwise, the trauma website has all the contacts for every trauma hospital in Minnesota.
Well, thank you for that on the fly answer. I love it. Full of knowledge, you over there. I appreciate you taking that question. We have about 7 minutes left, and I want to address one question that came in the last 12 hours from one of our participants. It's a doozy. So somebody had wrote in to say they're looking for some discussion on pediatric CPR due to choking and refractory VFib. So my pediatric emergency medicine colleagues, what kind of information would you like to give our EMS providers on this panel or non-participation? They're really two different. So CPR with choking, you come up on scene, they've got something lodged. It's helpless feeling.
I mean, choking scares me.
Yeah.
That is one of the worst scenarios to be in. And I apologize. I'm not sure if that falls on, I think it's BLS, but less than one, your back thrusts and chest compressions, and then greater than one, your Heimlich, as long as they're still breathing and have a pulse. And then if they lose their pulse, getting them started on CPR and getting them to an appropriate facility.
Yeah. I agree. I think foreign bodies and airway are the most terrifying. And so, yeah, I think whatever you can do, if they're breathing and maintaining decent oxygenation, again, that taking a position of comfort and not maybe being aggressive to them in their airway, like let them be in whatever way that they can maintain so you can transport. But if they're obstructed and not maintaining your PALs and algorithms and Heimlichs and then if you're looking, I mean, if you can get something out, great. Otherwise, there's always the thought of pushing it and right main stemming so that you can ventilate at least part of their lungs until you can get them to, obviously we'd be getting ENT or pulmonary, whoever at your institution would be actually going and scoping and trying to remove that foreign body.
One question I get from friends and family is about those D-choker and other devices you've all heard about. I mean, no one's ever going to be able to do a double-blinded placebo-controlled trial of Heimlich or nothing or D-choker, right? So I often say if it delays doing CPR, then don't do it. But if it's something, if it's because grandma can't do CPR, sure, try it. I don't, kind of bouncing off of that, it's something that's new to the market. So you may see people try that. I don't know, there's another device too, but I don't think we're going to know whether it's good or bad, but as long as it's not delaying other care, then I think it's not a bad thing.
Yeah, and then with the VFib arrest, I mean, defibrillation, following your algorithm, your PALS algorithm. I know from an adult standpoint, there's been a move to the dual synchronizing or kind of putting two sets of defibrillating pads on. I actually posed this question to our cardiologist due to a recent case I was involved with. And from a pediatric standpoint, that's not something that's been adopted. And the thought is at this point that the energy that the heart would need is just doesn't require that. And most of the time kids have healthy hearts. Their pathology isn't the same as adults for that. Definitely kids can have sick hearts. That's not to be said. But I'm sure I'm butchering it, but that dual synchronization has not been adopted in a pediatric standpoint. So it's really, kind of defibrillating and kind of per the standard algorithms. But I don't know if anybody else has comments on that one, but we don't see a lot of VFib. I would say we see more PEA and a systole, and it's often respiratory leading to cardiac arrest. Rare that it's a cardiac event that's the cause of it, unless obviously trauma or those kinds of things. And that's something to be thinking about, like obviously a sudden, like a baseball to the chest or something and somebody goes down, that's probably more likely defibrillation and VFib that you would need. But generally it's not something we see a ton of.
And for all that, remember, it's back to your basics,
Yeah.
back to your BLS, high quality CPR and respirations if you can.
And like Maria said, I think the more you could practice with your teams and your colleagues to run these things and know where your equipment is for these patients and those scenarios, it can deflate the emotion and the, I still get extremely anxious when we hear these calls coming in. So that is not to be said that changes anything, but I think it does help you feel like you know your algorithm, you know what you need to do. Even talking about it, if you're called out to these calls, like while you're on your route to them and saying, okay, this is a pediatric kid that sounds like might be in arrest. Like, what is the most likely we're going to be doing and thinking about, like, and just kind of talking through that plan. Just so when you arrive, you as a group are a uniform team, I think can be very helpful. So, cause these are not easy things to be doing. And I give you a lot of respect out in the field with the extra background that you're dealing with, including families. So thank you for the work you do, but I think it is going to be stressful no matter what. And we just want to acknowledge that for you too.
All right, well, thank you. I do not see anything in the chat. However, our contact information that Chelsea will put up. If you ever have any questions, again, Pediatric Readiness has some great resources along with EMSC. And, COVID did bring out a few great things. We have a lot of videos out there now that really show, they're 2 to 3 minutes on some really awesome ways to alleviate some stress when you're dealing with a pediatric injured or sick kid. So I've got one chat. Someone says, thank you. Well, I want to thank you guys for taking your Wednesday evening for us. I want to thank the panelists and thank Chelsea for putting this together and asking all of us to come. I've only met these people one time in person, and so it's been awesome. So
yeah, thank you all.
Yes,
some great questions posed, and we hope this will be the first of hopefully more. So give us feedback too. So, oh, Chelsea, is there any questions about CEU or how they might claim that or anything we should be